To be able to manage the epilepsy during pregnancy, you need to know about the history before pregnancy. You need to know your patient well. You need to understand how the medication worked, if the medication has been tried out to be the most effective dose, and you need to understand how sensitive your patient has been to changes in medication in the past. Have minor changes, for instance, forgetting a pill once or twice. Has that triggered seizures? In that case, it's an indication that your patient is very sensitive to minor changes, and that is important to know for the management during pregnancy. I think the need to monitor drug levels during pregnancy depends on your knowledge of your patient's sensitivity to changes in drug levels before pregnancy, but not least also it depends on which drugs you're on. And the need to monitor varies between drugs. Some drugs like lamotrigine and levetiracetam and oxcarbazepine, you have major changes in drug concentrations caused by pregnancy. And these I would definitely like to monitor frequently. Whereas other drugs, like carbamazepine, you in general see minor changes, and it's not that necessary to monitor the drug levels frequently. So it's about your patient and it's about your drug. The frequency by which you need to monitor levels depends on which drug you have and how sensitive your patient has been. I would say for a drug like lamotrigine, where we see the most marked changes, I would say once a month. I know that in the US, one often recommends even more frequent monitoring, but I think once a month is a reasonable thing. And if you see major declines, then you need to adjust your monitoring schedule and maybe do it more frequently. The way you react to a declining serum concentration again depends on how sensitive your patient has been to such changes before pregnancy. I think that, and also, you need to know what the concentration was before pregnancy, when the patient was doing well. If you have good indications of that the drug level you have as a reference before pregnancy was obtained when the patient was treated at the lowest effective dose, then I would be proactive. I would increase the dose in response to declining serum concentration with the aim of maintaining the concentration that was optimal before pregnancy. I would not wait for a seizure. I think you should be very careful with major changes like stopping a medication during pregnancy, even if that medication is associated with some increased risks, because stopping medication quickly is really a high risk for the patient and for the fetus. You may provoke seizures, you may even provoke status epilepticus that may have even fatal consequences. So a rapid discontinuation of the medication during pregnancy is something that I would rarely recommend. If I have increased the dose of the anti-epileptic drug during pregnancy, I should be aware of that the what we call the pharmacokinetics of the drug, the way the body is handling the drug, goes back to normal very soon after delivery, within days or a week. So I need to adjust the dose. I need to decrease the dose within a few days after delivery. Otherwise there's a risk that the woman will have symptoms of overdosing.